Hello students, my name is Oleg Bychkov. I am Associated Professor of Department of Propedeutics of Internal Medicine number 2. We continue our lecture courses, and today the topic of our lecture is the science of respiratory diseases, auscultation of the lungs. As you see on our slide, auscultation means listening to the sounds inside the body. It was found by French physician Oleg in 1816. He was the founder of auscultation and invented the first stethoscope. As you see on this slide, stethoscope was a tube, yes, and the first stethoscope by Oleg, it was tube of paper. And this how looks like modern stethoscope. As you know, we use such type of stethoscope or stethoscopes, and this type of stethoscope, which were used earlier in the medicine practice. So nowadays such stethoscopes are used only by obstetricians. So we use such type of stethoscopes. So what means auscultation? So auscultation techniques. So first of all, we need to know rules. There is rules of auscultations, such as in previous lecture about rules of percussion. Now we need to know about rules of auscultation. So first of all, the environment should be quiet and free from the distracting noises, comfort for the undressed patient. Place the stethoscope on the naked hairless skin. Hold the end piece between the fingers, pressing the diaphragm firmly against the skin. Avoid touching the tubing with your hands, movement of a patient or stethoscope, except for the respiratory excursion. So if you know these rules, make auscultation right, you will hear without any extra noises, and you will hear sounds which you need. Techniques of the lungs auscultation. Ask the patient to breathe slowly and deeply through the mouth. To auscultate the anterior chest, ask the patient to sit erect with the shoulders back. Then have the patient sit more erect with arms overhead for auscultation the lateral chest. Finally, ask the patient to sit as for percussion, with head bent forward and arms folded into the front to enlarge the listening area for auscultation of the back. So, as you see in this slide, auscultation we make such as a percussion on the front side, lateral side, and the back side of the patient. Place stethoscope in strictly symmetrical points of the right and left sides of the chest. Use the same order as with percussion. Move downward from the apex to base. Listen systematically at each position throughout inspiration and expiration. As you see, we need to make auscultation, and you need to remember this at each position throughout inspiration and expiration. This is very important. On the picture, you see suggested sequences for the systematic percussion and auscultation. And if you remember previous lecture, points of auscultation, as you see, are the same as percussion. So we make auscultation in the symmetrical points on the right part of the thorax and left part of the thorax. So why we use auscultation, what we what we are looking for to find in the patient. So first of all, you need to remember normal breathing sounds. So we have three types of normal breathing sound: vesicular, bronchovesicular, and bronchial or tracheal breathing. So characteristics of normal breathing sound. So vesicular. First of all, vesicular breathing is heard over most of the lung fields. It is low pitch, soft and short expirations. On the picture, you see that vesicular breathing, we hear inspiration and only 1/3 part of expiration. Next one, bronchovesicular. Heard over main bronchus area and over upper right posterior lung field. Medium pitch, expiration equals inspiration. So on the picture, you can see that inspiration are the same as expiration. And the third one, bronchial or tracheal breathing. Also, you can read that it is called tubular breathing. So it is heard only over trachea, high-pitched, loud and long inspirations, sometimes a bit longer than inspiration. As you see on the picture, high-pitched breathing and inspiration and expiration. Expiration should be heard more loud. As you see it in the picture, in each type of breathing, we compare inspiration to the expiration. That's why, if you remember previous pictures, one of the rules, it was listen to inspiration and expiration. So it is very important to find what type of breathing you hear in the patient. So expected auscultation sounds. So where we normally auscultate different types of breathing. As you see, all lung field, we hear vesicular breathing. So vesicular over lesser bronchi, bronchioles, and lobes. Bronchial breathing, we hear only on trachea, over trachea. And bronchovesicular breathing, main bronchus and right bronchi, main bronchi. So that's places where we normally hear breathing sounds. So remember, if you hear bronchial breathing or bronchovesicular breathing in the different places than trachea or main bronchus, it will be pathological. So normally it can be heard only on these places. So characteristics of the breathing. So vesicular breathing arises due to vibration of the elastic elements of the alveolar walls. Can be heard during the entire inspiration and the first third of the expiration, pronouncing as the sound. So as you see on the picture, vibrations of the elastic elements of the alveolar walls causes sounds, and the sounds we hear on inspiration and only 1/3 part of expiration. So if you take at home your stethoscope and listen to your colleague, so over, and he is healthy, so all over the lung fields you will hear vesicular breathing. What changes of the vesicular breathing we have? So vesicular breathing can be pathologically weakening, physiologically intensification. So physiologically weakening occurs in patients with a thicker chest wall. Physiological intensification occurs in the patients with a thin chest wall during exercises. So it is physiological changes. So asthenic patients, hypersthenic patients, so they will have physiological weakening or intensification of the vesicular breathing. Physiological changes in the vesicular respiration always involve both parts of the chest. So you can't hear physiological changes in the one part and don't hear it in the another part. So physiological always involve both parts of the chest. Pathological changes. So when we can hear pathological vesicular breathing. So first of all, pathologically decreased vesicular respiration. One of the most popular changes of the vesicular breathing. Remember these pictures, they were on palpation, they were on percussion. Now we will have them on auscultation. So pathologically decreased vesicular respiration can be due to, first of all, accumulation of the fluid or air in the pleural cavity. If you remember, fluid pleuritis, accumulation of the fluid in the pleural cavity, or pneumothorax, accumulation of the air in the pleural cavity, it will cause pathologically decreased vesicular respiration. So we hear very short inspiration and very small part of expiration, or expiration can be even not be heard. Next reason, thickening of the pleural layers and obstruction atelectasis. So this one, it is thickening of the pleural layers and obstruction atelectasis. So this is also reason for pathologically decreased breathing. Next reason, pulmonary emphysema, inflammation and swelling of the walls, inflammation of the respiratory muscle, intercostal nerves, and rib fractures. On this picture, you can see what it means pathologically decreased vesicular respiration. So normally, as we mentioned, we have inspiration and 1/3 part of expiration. Due to these changes, which we said, we'll hear shorter inspiration and very small part of expiration. So if you hear expiration very, very low, it is very short, it is pathologically decreased vesicular breathing. Next change, as it was physiological, decreased, increased, so pathological, abnormally increased vesicular breathing. Expiration becomes louder and longer. Pathologically increased vesicular breathing we called harsh breathing. It occurs in narrowing of the lumen in small bronchi and bronchioles due to inflammatory edema of their mucosa. So disease is bronchitis. So very popular disease, and if your colleague has or friend in some period of time has bronchitis, so if we make auscultation of them, we will hear harsh or increased vesicular breathing. So as you see on the picture, we have inspiration and the same expiration, and it becomes louder. So harsh breathing. Next, our bronchial breathing. So bronchial breathing arises in the larynx and the trachea as air passes through the vocal slit, becomes louder, harsher, and longer in expiration. Is well heard over the larynx, the trachea, and at the points of projection of the trachea tracheal bifurcation. As you see on the picture, we have inspiration and longer and louder expiration. So this is bronchial breathing. Remember, bronchial breathing we hear only on the trachea. Vesicular breathing we hear over the lung fields. Pathological bronchial breathing. So if we hear bronchial breathing, so we hear loud expiration, long inspiration in the lung fields, we call it pathological bronchial breathing. So reasons. First, empty cavity in the lung. So tuberculosis, we will hear pathological bronchial breathing. Next one, induration of the pulmonary tissue or compression atelectasis. So as you see, the reasons for pathological bronchial breathing, it is consolidation of the lung tissue. So in the consolidation of the lung tissue, we will hear pathological bronchial breathing. Types of pathological bronchial breathing. We have amphoric, metallic, and stenotic. Amphoric arises in the presence of the smooth wall cavity, not less than 5-6 centimeters in diameter, communicated with a large bronchus. Metallic is heard on the open pneumothorax when the air of the pleural cavity communicates with the external air. And stenotic pathological bronchial breathing is heard in cases with narrow trachea or a large bronchus. So, 3 types of pathological bronchial breathing. Bronchophysical or mixed respiration. As you remember, normally bronchophysical breathing we can hear only in the projection of the main bronchus. So pathological bronchophysical breathing we hear when focus of the consolidated tissue being seated deeply in the pulmonary tissue and far from one another. So we have inflammation in the lung tissue and it's far from one another and is situated deeply. In this case, we will hear bronchophysical breathing. Next step in our auscultation is to find presence of adventitious breath sound. So adventitious breath sound divides on crackles, ronchis, whistles, friction rub, mediastinal crunch. Crackles can be fine, medium, and coarse. So crackles. When the crackles are heard at the end of the inspiration and in the beginning of expiration, the fluid of secretion are probably in respiratory bronchi, medium crackles. If the crackles are heard throughout, it implies the secretion are in the bronchis, coarse crackles. So crackles, interrupted adventitious sound, are called crackles. When you make auscultation, make a notation about timing, intensity, effect with respiration, position, coughing, and character of the courses which you heard. So timing and intensity. Crackles heard only at the end of inspiration are called fine crackles. When the surfactant is dipped, the alveoli collapse, air enters the alveoli at the end of inspiration. This sound is generated as the alveoli pop open from its collapse state. So let's look at the picture. We mentioned coarse, medium, and fine crackles. So, coarse crackles, you see they are big, is heard on inspiration and expiration, medium and fine. So if you mentioned things which we heard, which we talked about, so period, sound, characteristics of this adventure sound, you will check if it coarse crackles, medium crackles, and fine crackles. Ronchis. Ronchis are long, continuous adventure sounds generated by obstruction to airways. So if we compare to the crackles, crackles appear when we have fluid, sputum, edema in the bronchus. Rhonchi appears due to obstruction of the airways. When they are detected, note whether it is generalized or localized during inspiration or expiration and the pitch of the rhonchis. Diffuse rhonchis would suggest a disease with a generalized airway obstruction like asthma or COPD. Localized rhonchis suggest obstruction of the any etiology, like tumor, foreign body, mucus. Mucous secretions will disappear with coughing. So would the rhonchi. Expiratory rhonchi implies its obstruction to the interthoracic airways. Asthmatics can also have inspiratory rhonchis while it uncommon in COPD. Wheezes. So wheezes is a continuous, high-pitched musical sound, almost like a whistle. It's heard during inspiration or expiration. Is caused by a relatively high-velocity airflow through a narrowed airways. If a whistle is heard bilaterally, it may be caused by the bronchospasm of asthma or bronchitis. Unilateral localized wheezing may occur with a foreign body or tumor compressing. Pleural rub. So normally, parietal and visceral pleura glide smoothly during respiration. If the pleura is roughened due to any reason, a scratching, grating sound related to respiration is heard. So you can hear the sound by compressing harder with the stethoscope and making the patient take deep breaths. It is localized and can be palpable, so you auscultate it, and when you put your hands, you can also feel this rub. Stridor. Loud, audible inspiratory rhonchi is called stridor. Inspiratory rhonchi in general implies a large airways obstruction. So if you have obstruction of the large airway like trachea or main bronchi, we will have such additional sound like stridor. So, and in this page, we can compare what we listen in which part of breathing and how it feels. So, fine crackles, we auscultate on the third part of inspiration. Medium crackles, they are bigger and we auscultate it in the medium part of inspiration. Also, it can be heard in expiration. Coarse crackles, big sound. Rhonchis and whistles, inspiration and expiration, more on expiration. Whistles, so it is melodic sound, yes, and pleural friction rub. So in which part of our respiratory system we have problems, so where we can hear some different sounds. So bronchis, coarse, low-pitched, may clear with cough. And you see reasons of bronchis, it is bronchis. So with whistling, high-pitched sound. So if bronchis, it is big bronchis, so whistles, it is small bronchis and bronchioles. Next one. Rub. So friction rub, it is pleura. So pleural friction rub. If pleura is damaged, we can hear this friction rub. Remember to hear rub, as we mentioned. You also can palpate this rub and push stethoscope to hear it better. So crackles. Crackles, fine crackles, medium crackles, and coarse crackles. So it is bronchioles, bronchis, and fluid in the bronchis, such as sputum, and so on. So thank you for your attention.